Good morning. Every stroke patient teaches us something new. Let's start with a case. This is a story of a 55-year-old gentleman who suffered left hemiplegia and reached the hospital within 5 hours. He was beyond the window period for IV thrombolysis. CT angiogram showed that there is an occlusion of the right internal carotid artery. So immediately he was taken up for a digital subtraction angiography, which showed that this is the right common carotid angiogram, which shows that the right common carotid artery, the internal carotid artery is completely occluded at its origin. The external carotid artery is normal. There is no flow. It is more like a stump. So left internal carotid artery injection shows that the MCA territory is normal. Both ACAs are filling from this side. There is the ACA on the right side also is being filled from the opposite side. But the A1 is occluded here. That means the MCA is occluded. It's either a T occlusion or an M1 occlusion. The MCA territory is completely occluded. The vertebral artery is not supplying to the middle subral artery territory. So this is the occlusion. So since the patient had a dense deficit and was within the window period, an attempt was made to open the vessel. So this is the attempt to open the vessel. A wire was tried to manipulate through the site of occlusion. With some manipulation, the wire easily went up through the occluded segment into the occluded internal carotid artery. A balloon plasty was done. You can see the balloon with which the occluded segment was dilated a bit. A guiding catheter this is the guiding catheter which was taken into the occluded internal carotid artery, and an injection into the internal carotid artery showed that the carotid artery here looks normal. This is the ophthalmic artery, and the occlusion is distal to the ophthalmic artery. So there is a proximal occlusion and a distal occlusion. The aspiration catheter was taken. This is the tip of the aspiration catheter inside the at the occluded segment. Aspiration was done. The MCA opened, but there was one branch which was still occluded, which was cannulated with a microcatheter and a wire and a stent retriever and the Solumbra technique. The whole MCA opened up. Previously, if you remember, it was occluded somewhere here. It was more like a T occlusion. The distal ICA, M1 and ACA all three were occluded. End of the procedure, this was the area which was occluded, but after leaving the guiding catheter inside the internal carotid artery for some time, it was converted to something like a 60% stenosis. So there is an area which is, the carotid looks okay. There is a 40% stenosis. A check angio after 15 minutes showed that it is stable. It was left like that, and patient had a good recovery. So in this next 15 minutes, I'll just share you 10 things which every one should know, or 10 things which I would like to share with you regarding these abnormalities which are called tandem lesion. The first thing that I'm trying to discuss is what exactly is a tandem lesion. A tandem lesion is defined as a severe stenosis or occlusion of the cervical internal carotid artery, which is ipsilateral to the intracranial occlusion. I'll make it more clear. You have the common carotid artery. There is a proximal internal carotid artery lesion here, and there is a distal occlusion. So you have two lesions. One is a proximal internal carotid artery occlusion and a distal occlusion in the MCA or in the distal ICA. So this is when they have two lesions, that is called a tandem lesion. The second thing which I would like to discuss is why every neurologist should know about a tandem lesion. At least 15% of the patients undergoing, at least 1/5 of the patients undergoing an endovascular thrombectomy for an anterior circulation acute ischemic stroke have a tandem lesion. So that means if you take 100 patients for IV endovascular thrombectomy, at least 20 people will have a tandem lesion. So we should have a clear understanding of what is the importance and what are the technical difficulties in that. The second thing is patients who have tandem lesions have usually worse outcomes than patients with isolated intracranial occlusion. Like when you compare a patient with a middle subral artery occlusion or an M1 occlusion alone with a patient who has a tandem lesion, the outcome is much worse in a patient who has a tandem lesion. When you take IV thrombolysis, intravenous thrombolysis is less effective in patients with tandem lesion. Obviously, one, because the clot burden is much bigger. You have a proximal lesion as well as a distal lesion, so the clot burden is significantly higher. Second, because the proximal lesion is occluding the flow to the site of occlusion in the MCA territory, the intravenous drug cannot reach the thrombus and cannot lyse the thrombus. Second, and last but not the least, the patients with tandem lesions, even though they were included in the major randomized control trial, the number was very less, and they were not assessed or analyzed later in a randomized way, so that there is no firm recommendation about what should be the optimal management. And hence, the treatment decisions are often very, very complex, and strategies vary according to the clinical feature, like the patient having a dense deficit or a mild deficit, what are the anatomical angioanatomy, the technical considerations, and in addition, what is the physician preference or the preference of the interventionalist in doing the treating lesions, patients who have tandem lesions. Now, what is the mechanism of stroke? The mechanism of stroke is simple. It is an artery-to-artery embolism. You have the proximal lesion here, which could be a carotid stenosis or a dissection, and from here, an artery-to-artery embolism occurs. Either it could be a thrombus or a atheromatous plaque or a material which gets dislodged and gets occluded distally. So this is the pathology or the pathological substrate of a tandem lesion. Now, what are the four things that can produce a tandem lesion? One is obviously a carotid stenosis. Second is a carotid dissection. Third, a carotid thrombus. The carotid thrombus assumes significance in this era of COVID, when people have a procoagulant state, a pro-thrombotic state, and large thrombus can get occluded in the proximal internal carotid artery, especially when there is a 20 or 30% stenosis, or people who have a carotid web, and from there a fragment can get dislodged and get occluded distally in the middle cerebral artery. Carotid artery stenosis was majority belong to this category. 20 to 30% are due to dissection and rarely due to carotid webs and carotid emboli. Now, how do you differentiate between carotid dissection and atherosclerosis? Carotid dissection is the intima there is a small break in the intima, and blood seeps between the intima and the adventitia, the media, and that raises the flap and leading to occlusion of the blood vessel, and this is what happens in carotid dissection. Dissection usually occurs not proximal to at the bifurcation, but usually distal, more than 2 centimeters from the ICA origin. It's often near the skull base. There will be a double lumen or an intimal flap, and internal carotid artery wall hematoma could be demonstrated, and usually dissection occurs in younger patients. This is an example of a crescent sign which is seen in the axial sections. You can see the wall hematoma. You can see a pseudo aneurysm here with a small thinned out vessel, which is characteristic of dissection. Another CT angiogram showing a very thinned out vessel, and this is a patient who has fibromuscular dysplasia. You have the characteristic appearance of the fibromuscular dysplasia and dissection of both internal carotid arteries. In contrast, atherosclerosis occurs at the origin of the internal carotid artery. There is usually a calcified plaque which is adjacent to the stenosis, and there will be evidence of atherosclerosis in other arteries also. So this is the characteristic appearance of the atherosclerosis, a tight internal carotid artery stenosis here, another patient with a tight internal carotid artery stenosis. Now, the fifth thing which I want to discuss is what are these entity called pseudo-occlusion. When there is a thrombosis in the distal internal carotid artery or the proximal MCA, this leads to a flow-related artifact which can lead to the misdiagnosis of a proximal ICA occlusion, and in fact the extracranial internal carotid artery is patent. You can see in this example, this looks like a flame-shaped occlusion. So this looks like a flame-shaped occlusion, but actually if you look carefully, there is actually distal flow, and the occlusion was actually much distal. So these are the three characteristic types. One is a dome, the other is a beak-like appearance which I showed previously, and the other is a flat. So either a dome or flat is very characteristic of a true proximal internal carotid artery occlusion, whereas a beak-like pattern, a tapering occlusion, there is as you go distally, there is a diminished contrast filling of the distal margin of the contrast filled proximal ICA. So there is a thinning out here, we can see here, and this is very characteristic of a internal carotid artery pseudo occlusion. The seventh thing which I would discuss is how do you manage these patients. So this is essentially a chart which shows the treatment options in a patient who has tandem. You have a patient with a tandem occlusion. You can decide to either treat the proximal internal carotid artery lesion in an acute stage itself by either doing an angioplasty alone. Just do a balloon angioplasty. If there is a clot, you can do a thromboaspiration. Majority, if there is a significant clot burden, a thrombus aspiration can be done, or in the acute phase itself, consider carotid stenting. Now, if you are planning to do carotid stenting, there are two ways in which can be done: andrograde and retrograde. Andrograde means you first do the carotid stenting and then through the stented artery go up and open the middle subdural artery. The second option is don't disregard the proximal internal carotid artery. Take care or attack the middle subdural artery occlusion first, and then at the end of the procedure decide whether you want to do a carotid stenting or not. And then there are other issues like what should be the type of stent used, should we use a distal protection device, should we use a proximal flow arrest, and what should be the optimal antiplatelet regime. Now the second decision that has to be taken is whether the internal carotid artery stenting has to be deferred or you don't do anything for the internal carotid artery, and eventually take the patient for a carotid endarterectomy or carotid artery stenting, or decide that the patient doesn't need an internal carotid artery intervention. In situations like when the patient has got a very large infarct, the outcome is going to be poor. There is end of the procedure, you keep the guiding catheter in the internal carotid artery for a long period of time, and there is a significant expansion of the carotid stenosis, and there is no significant residual stenosis. And last but not the least is the pseudo occlusion which I discussed, where it actually not a true occlusion but a collapsed vessel because of a distal occlusion. Now the seventh thing which I would like to discuss is what should be the strategy. Should an acute carotid stent be placed in conjunction with the thrombectomy? Now what are the benefits and risks of doing acute carotid stenting? The benefit is, one, the causative lesion is actually the proximal carotid lesion. You treat that causative embolic lesion. Because you leave it there, the chance of again the patient having a recurrent event is much higher. Second, it improves. If you open a 90% or an 80% stenosis into a 20% stenosis, it improves the cerebral perfusion, and usually this reduces the infarct progression and the eventual outcome might be significantly better. Third, when the carotid flow is improved, it might lead to spontaneous clot lysis also. But what are the risks involved? One is an artery-to-artery embolism. When you are dilating the carotid artery, when you are putting a stent and doing a post-stenting dilatation, there is always a chance of artery-to-artery embolism. And second, stent thrombosis. This is a stent which, and in a patient who is in the acute phase, may not be properly on an antiplatelet regimen, and hence the chance of the patient having a stent thrombosis also is higher. And third is ICH or hyperperfusion bleed, especially when the patient has already received IV thrombolysis and is receiving antiplatelet medications also. Now, what are the factors which influence decision making? One is the use of IV thrombolysis. So the patient has already received IV thrombolysis and you have given antiplatelets also, either intravenous antiplatelet medication, and you are planning to do the stent, the chance of bleeding is high. So you have to decide whether it is actually required or not. Patients who are prior on antiplatelet medication, then the decision to stenting is much easier because the patient is already on antiplatelet medication, the chance of stent thrombosis is less. The degree of collaterals. If the collaterals are good, then naturally maybe you can wait for some time and do an elective stenting. And what is the degree of final intracranial recanalization? If the intracranial recanalization is very good, a 50% stenosis of the proximal carotid artery can be left alone. Degree and morphology of the residual ICA stenosis. Suppose if it's a very unstable lesion, if there is a rupture of the plaque, if there is a small dissection there, and if you wait for 5 or 10 minutes and do a repeat angiogram and shows that it is unstable, it is occluding again, then probably you will have to stent it. Etiology of the stenosis. Atherosclerotic lesions are better stented, whereas dissection can be left alone, usually heals over a period of time. Presence of hemodynamic symptoms. Suppose if you feel that the patient, even after opening the MCA, the patient has not improved significantly, and there is a fluctuation of weakness suggesting that probably opening up the proximal carotid might help, then you can consider stenting. Pre-EBT infarct volume. If the aspect score is poor, if it is very low, the chance of a hemorrhagic transformation is higher. So that also should affect or influence your decision to stent the patient. So this is roughly a chart which summarizing the chart which I have discussed. A large infarct volume, then no stenting, good collaterals, the circle of Willis is complete, the patient is likely to do well, then no stenting. There is no active reocclusion. That means you wait for some time and the vessel is not occluding. You can wait for some time or maybe do an interval stenting. Use of IV thrombolysis. If the patient has already received IV thrombolysis, opening the vessel completely might lead to a higher risk of bleeding, and hence maybe a stenting may be deferred. Now the next thing which I would discuss is, should the intracranial or the extracranial lesion be treated first? The MCA should be opened or the carotid should be opened first. The first is called an andrograde technique. That means you treat the carotid artery first, and the second is you treat the middle subtle artery first and do the carotid second, which is called a retrograde technique. The advantages of a retrograde is it leads to shorter intracranial recanalization time. Why the patient has suffered a stroke is because of the MCA occlusion or the distal ICA occlusion. The MCA is not getting blood because the M1 is occluded. So open that first, put a stent retriever there, aspirate and open that vessel. At least there will be some amount of circulation into the middle subtle artery, and that will be, it leads to a shorter intracranial recanalization time. Second is, when you put the stent first in the carotid artery, and when you try to retrieve the stent retriever, there is always a chance of the stent retriever getting stuck in the carotid stent, unless you have take the guiding catheter up and take the stent inside the guiding catheter. Then third is, if you do it first, the patient can have a bradycardia or hypotension when you dilate the stent. This has happened to me once. When you, at the time of stenting, there was a significant bradycardia and the patient almost went into asystole and arrest. And so it took almost 15 minutes to, again, the patient had to be intubated, the patient had to be, shock has to be given. It did not revert with atropine. So almost lost around 15 minutes in that process, and that delayed the intracranial recanalization. Keeping the guiding catheter maybe for 15 minutes now, the time you take to open the middle subtle artery, it might be enough to open the carotid stenosis to convert to something like a 50%. And last, it prevents thrombus dislodgement. When you are doing the stenting first, always there is a chance of artery to artery embolism. And then the next topic is, what should be the type of stent used? This varies from depending upon the physician preference. A closed cell stent, the chance of embolism might be less, but if it's a tortuous or a curved artery, then open cell might be better. Balloon angioplasty before or after the stent deployment. These are issues now which, depending upon the type of the plaque, whether it is a smooth plaque, whether you want to completely open up the vessel or leave it something like 70% open, which might be enough in most of the situations, has to be taken on a case-by-case basis. Now, what should be the anti-thrombotic regimen? The problem is whether you have to balance between an instant thrombosis, the stent getting thrombosed, versus a hemorrhagic risk. If the patient has received IVT, then usually 300 mg of IV aspirin is given, IV if it is available, otherwise load through a Riles tube. And whether IVT was given or not should influence the decision. Peri-procedural aspirin you give 300 mg, and clopidogrel bolus, if the patient has not received IVT, can be given along with that. Suppose if the patient has received IVT, then the clopidogrel bolus is delayed till you get a repeat CT and be sure that there is no bleed. Now, what is the role of an embolic protection device? Using an embolic protection device in such a situation usually will delay the procedure much more. So many times in an acute setting like that, an embolic protection device is used, not used, but if depending upon the physician preference, it can be decided. It can be used or not. And the decision to do delayed carotid revascularization in patients who have not undergone stent, that is also a decision. When to do that is a decision which has to be taken by that particular department, their protocol. Now finally, the last thing which I would like to discuss is what is, in summary, the current evidence of management. If you look at all the major trials, the first is actually the Hermes trial. There were 122 patients who had tandem lesion, but there were no clear guidelines. The treatment of it was actually not different. The outcome was comparable. The hemorrhagic risk was also comparable. In the ESCAPE trial, acute carotid artery stenting was done in 26%, Mr. Clean 40%, Ruascat 50%, Dawn and diffuse, there was no definite guideline. There are currently two trials going on, the Titan trial and the EasyTalk trial, which is actually, this is a randomized trial of patients with tandem lesion undergoing endovascular thrombectomy. The conclusions are future. The patients, the first question that should be answered is whether these patients should be offered the option of benefit of thrombectomy. Yes. Just because the patient has got a tandem lesion, they should not be denied the benefit of thrombectomy. The outcome in such situations, if you don't open the vessel, is extremely poor. So definitely, yes, that is very sure. The patient should be given the option of mechanical thrombectomy, and knowing fully well that the outcome may not be that good. And observational studies suggest that when you combine an acute carotid artery stenting with endovascular thrombectomy, that may be the best treatment strategy, but may be left to the treating physician depending upon the status of the carotid or the prevailing circumstances in that particular case. The outcomes are much better if you combine an acute carotid artery stenting, better carotid patency. Because one of the problem is when you leave the carotid like that, you never know, whether it will get occluded. Next day the patient deteriorates, you are in a doubt now whether the carotid has occluded again. So that creates a dilemma, and so the management of the patient is much easier if you stent the patient in the acute phase itself, provide maybe we can wait for half an hour, load the patient with antiplatelet medication and do a stenting after half an hour. The randomized control trials like the Titan and the EasyTalk might give more answers. So the general approach which is being followed as per the available evidence is always aim for the intracranial lesion first. The MCA occlusion is the culprit, so always open the MCA first. That is the retrograde approach. Then decide regarding what to be done for the proximal carotid lesion. Acute stenting, especially when there is a poor circle of Willis, there is a disease of the opposite carotid artery or a near normal baseline CT, then an acute stenting should be considered. Dissection is usually a self-healing process, so better leave it as such. Usually it heals by itself. Antiplatelet medication, if the patient has received IV TPA, you can load with aspirin alone, and the second antiplatelet medication, Plavix, can be loaded later. And if the patient has not received IV TPA, loading dose of both aspirin and clopidogrel can be given. Now, what are the alternate approaches available? Like there is a good circle of Willis and there is a huge thrombus there, and you think that the dislodging thrombus and the thrombus going up into the middle subarterial territory might be more damaging, and the collateral flow is pretty good, and the patient's neurological deficits are not that bad, then you can sacrifice the carotid when there is a large intraluminal thrombus and the collateral flow is very good. The other is what is called there is a new technique which is revised care technique, where you do a simultaneous treatment of the atherosclerotic tandem occlusion on the same wire. The technique is a modification, like you deploy the stent retriever, take out the micro catheter, and on the wire of the stent retriever, use that wire to stent the carotid lesion. And once you finish the carotid stenting, by the time you wait for 5 minutes for the stent retriever to engage the clot, you do the carotid stenting also. That is a modification of a new technique which has been suggested. So this is the technique. You deploy the stent retriever in the middle subarterial territory. You make a bare wire, that means take out the micro catheter of the wire, and over that wire, use that wire to do a dilatation of the proximal carotid artery, and over the wire, using that wire to deploy a stent, and end of the procedure, you take out the stent retriever and open the MCA. So in the same 5 minutes, you can do the carotid stenting as well as the distal stenting. So summary, the benefit of intracranial thrombectomy in the tandem situation makes no doubt. There is no doubt that the patients will benefit even in patients with tandem lesion. But there is a controversy whether the cervical lesion, how to manage, whether you should stent the lesion or not, and definitely the answer will be given only by a randomized trial. So till then, all these factors should be discussed in each individual patient, and an appropriate decision should be taken. So this is for the benefit of all the stroke neurologists who may not be doing intervention. Knowing all these problems, the controversies, will help you to participate in the discussion process and make an informed decision whenever you come across a patient who has a tandem lesion. Thank you for your patient listening. If you have any doubts, or if you have to discuss further on that, and I would like to hear the opinion of the other expert panelists also at the end of the of this particular session. Thank you.